Welcome to today's FQHC Connect webinar, which is a fireside chat, hidden risks in your peer review process, how common myths could cost your FQHC in compliance, coverage, and patient trust. I'm your host, Steve Weinman, principal with FQHC Associates. Today, I have the pleasure of being joined by two distinguished guests. First is Misty Schell, Senior Director of Clinical Operations at Medplace. And secondly is Cherie Vivian, Director of Healthcare Quality with Franklin Primary Care, a large community health center in Mobile, Alabama. So Misty and Cherie, welcome to FQHC Connect.
No.
Thank you for having us.
Happy to have you here. So hi, Misty and Cherie. So I'm going to start with you, Misty. Tell us a little bit about your background and how you got into this peer review business.
Yeah. So I have been in healthcare for over 25 years. I began my career as a nurse and LPN, and through the years, just really moved into operational leadership within healthcare settings. I made a big shift from the dermatology field to FQHCs during COVID. I was very crazy during that time, but was able to do a lot of really amazing things with an FQHC out in Colorado. And then recently worked for an FQHC here in Missouri, where I'm currently at. Really just helping to operationalize clinical teams and help to optimize care and focus on quality of the health centers. Peer review is something I know well. I know the pains of peer review and the burdens that it puts on teams internally as well.
Yeah, peer review I always felt when I was running the health center that getting our providers to do peer review was a little bit like getting a kids to eat broccoli.
Absolutely.
I mean, no matter how much I told them it was good for them, they didn't want to do it.
Nope.
So Cherie, tell us a little bit about you and your health center.
Sure, of course. So I am the Director of Healthcare Quality. I've been with Franklin almost 4 years. Similar to Misty, a registered nurse. I have my BSN, started as an ADN, BSN. And during COVID, I decided that I wanted to go back to school and continue my education. So I got a master's in public health. And when researching what to do with that master's, I found Franklin. And Franklin has been in Mobile, Alabama since 1975. So 50 years we've been here in this area. We're in 6 different counties in Alabama, and we have 20 locations. All of those locations are accredited by the Joint Commission. We also are recognized by NCQA as patient-centered medical homes, and we also have the HRSA deemed applications that we always do every year for our FTCA coverage. So Franklin is really big in this area. We help those that are uninsured, underinsured, and we don't turn anyone away. That's our philosophy and our mission. So it's a important piece of that, of course, is peer review. Because without a good peer review, you won't know where you stand, what kind of quality of work you're actually providing your patients.
Yeah, you're preaching to the choir here. And I guess lately, this has got a lot of attention because of the changes to FTCA and how they're suddenly paying attention to quality in a way they never have before.
Yeah, the applications are definitely more quality driven, and risk management plans are going to be scrutinized. And part of that is your peer review.
Yeah, it's funny. I can tell you way back when I started and they first had FTCA, literally when you did your competing grant, it was like 3 questions that they asked you, and that was
Wow.
it. And it has certainly evolved.
Yeah.
Changed a lot.
To say the least, it's evolved.
A lot. I think as the lawsuits have come.
Right, exactly. The claims, exactly.
So,
And
Misty,
that's how Medplace came to get
go
to know
ahead.
Cherie.
Exactly.
Franklin is one of our clients. We provide peer review service. We take the burden and the weight of the peer review off of her team so that they can get unbiased reports back and really be actionable with their peer reviews.
Mm-hmm.
All of us have to do peer reviews, right? Every health center has to do them.
Mm-hmm.
And a lot of times, and I know in my personal experience, I never felt like I was really truly getting unbiased peer reviews back from our providers. It kind of felt like we were just checking a box, and then normally my reviews just went into a folder somewhere. They were there if I ever had to show a surveyor, if they showed up on site, and asked what my policy was and what we were doing. And so, Medplace has been able to come in and really say, let's make these valuable for you. Let's help you look at your information, your reporting. Let's take the bias out of your peer review. And that's what we'd really like to talk about today. How do we avoid those rubber stamped, just biased reviews? And what are surveyors now really looking for, and why is that important?
Yeah, one time I had a medical director whose care was a little bit questionable, and the other providers that were having to do his peer review, and they're like, "How can you ask me to critique my boss?" So it never really worked the way it was intended.
Yeah,
So,
exactly.
so Misty, I know you've got some slides to share with these folks, so if you want to bring them up.
Well, today we want to start off by doing a poll with you all. So we'd really like to kind of gauge what your perception is around peer review. And I think that will help guide maybe some of our Q&A later as well. So I know Steve's going to start us off with a poll.
Well, I think we've got 133 answers here, so it looks like everybody mostly agrees that it's necessary, but and a lot of them think it's burdensome as well. Actually surprised it
Box checking.
isn't
Yeah, and
more.
I would love later in Q&A to maybe even hear, some people are saying efficient and impactful. I would love to hear some tips or tricks or thoughts from that group as well on what's been successful for their teams.
Yeah, the way I was successful was I got somebody else to deal with it.
Yes.
100%.
It was truly one of the things I hated most about my job as a administrator, was having to get in the middle of some of these conflicts that arose from this.
Yeah.
Well, and I think, just seeing everyone really, their feedback about it being burdensome and box checking, I know that for those of us that quality is a focus of what we're doing every day, it's very frustrating when we feel like we're doing a task out of necessity that's not making an impact in any way. And so really being able to, partner like with Cherie and Franklin, we've been able to really change that for them. Peer review is now impactful, is now creating quality initiatives, is now creating training for their providers. And so I
100%.
think being able to take something that it just is a burden and say, okay, it's actually useful now, and we've made it useful for us is really, really amazing. So, well, great. Well, thank you everyone for your feedback there. I think we're going to move now to just talking about some myths that come along with peer review. And I'm going to hand that over to Cherie to talk about for us.
Awesome. Thank you so much. So one of the myths is that annual is enough. I think that was one of the things that I kept trying to figure out was, how many are we supposed to do? We looked through every EHB, we looked at every website we could. This was a little bit before chat, GPT, before I think I maybe asked chat about it, how many, and how often. Those were some of the things that we never could find a defined answer through any through FTCA, Joint Commission, NCQA. They never really define. They just say, a select amount. Enough annually. They never gave you a time frame. So that was one of the things that we found out, that annual is not enough. When we had our OSV visit, it was not necessarily recommended, but we were told that quarterly is the best practice. And that's one of the things that we were attempting to do, but with the chaos of doing it prior to Medplace, doing 5 charts per provider per quarter was a daunting task. And it took a lot of man hours from our quality department and from our providers.
Yeah, Cherie, I think you call out a great point. Being a part of several accreditation and site visits, I always laugh because they don't tell you how to do it. You have to do it, but they really leave it up to each individual center organization to say, this is our policy and this is how we abide by it.
Yes.
And that's why it's so important. You have the autonomy to say what is impactful,
Mhm.
and being able to say quarterly is really impactful for Franklin, because then you can get ahead of things too. You can be a lot
Exactly.
more proactive.
Mhm.
You're not waiting a year later and going, oh no, this provider, why haven't we caught this? So
Yeah, exactly.
yeah,
But I mean,
And
a big
very
part of
powerful.
why we did that was when we had to do the peer review ourselves, at least in
Mhm.
my experience. First of all, let's suppose there was a provider out sick or went on vacation. So what are we going to choose to do? See the patients or do the peer review? So literally, we chose correctly to see the patients, and the peer
Mhm.
review got pushed to next month. And then
Mhm.
next month there was another problem. And
Mhm.
then it made it, and the thing that made it easier to do that is nobody wanted to do the peer review in the first place. So it's real easy to postpone, having broccoli for dinner. So literally, then we'd get to the end of the year and realize that we hadn't done
Hadn't
all the
done
peer
it.
review we should have
Mhm.
done, and we're having our OSV coming up,
Yeah.
and we have to scramble to try to do it all at once. Or we have a bad outcome, and then all of a sudden, when we're trying to figure out why that happened, let's have a look at his peer review. What do you mean we haven't done his peer review in 18 months?
Yeah.
And I mean, so normally it wasn't important until it was.
Mhm.
Yeah,
And see that kind of goes
100.
into in that internal sign off. We spoke about, how can you literally sign off on someone that is your boss, so to speak, or it's someone that you rely on or share clinic space with every day. So myth number two, is the internal sign off sufficient? And really, it's not. Having someone on the outside looking in who does not have a dog in the fight, who does not know these providers at all, never met them, and will probably never meet them, but can just look at the chart objectively and then give honest feedback, that has been priceless. And Misty said it, we have made all kinds of changes to our process internally in our EHR, how we document, just one of the examples, because now the outsider is seeing something that we didn't see. And so that's been really, really helpful for our organization.
So, Cherie, I would also think that the thing that makes it more valuable is just like me being a consultant on the outside. So, the
Exactly.
person who works at the health center maybe has seen one health center, maybe they've worked at three health centers over
Hmm.
their career, but
Hmm.
I've worked with over 200 health centers over my career. So, I see
Mhm.
trends and things happening. So, I'm constantly comparing what one client is doing with what I've seen before, of course, without naming anybody. And you have a much different perspective on it when you're able to see into multiple organizations rather
Ex-
than the only way you've ever seen it done is how they do it at
How
the
you
health
do it.
center. How do you know if it's right or not?
Mm-hmm. Mm-hmm. And that
Absolutely.
how you do it every day, always, it leads you to, like, you don't find out until OSV is at your door that what you're doing may not quite be compliant. So
Mhm.
myth number three, one of my favorites, is just compliance. No, it's not. There's no other way to say it. It's not just compliance. A good peer review can change the entire outlook and processes of your organization. We had a strategic plan to obtain quality badges and different things. Well, you have to start looking at your processes in order to obtain those badges and to meet those goals. So once we started hearing different things on our peer review about how we were addressing things like uncontrolled hypertension, were we assessing and documenting that second normal blood pressure, or if it never got normal, did we escalate to a higher level of care? We found those out during the peer reviews. So then that would affect our controlling hypertension numbers. So yeah, it's not just compliance. It really is a living, working part of your team.
Well, and if you do have a bad outcome sometime and you have to, God forbid, get rid of the provider because of something they've done, I
Mhm.
imagine it's a whole lot easier if you go back and you've got
Mm,
something to base it on.
Mm-hmm, mm-hmm.
absolutely.
100%. We only do our peer evaluations. There's clinical competencies every year, but our peer evaluations, our performance evaluations are every 2 years. And no one wants to wait 2 years to find out that you may have a potential problem in your organization.
Absolutely.
Yes.
Mm.
Yeah. So myth number four, I think the one that probably is one that's going to be resonate a lot to a lot of FQHCs, especially right now, is external reviews are too expensive. I can't put a dollar amount on the hours that myself and my team have gotten back to focus on other more important objectives and things that we set as a quality department away from the peer review, because it's probably maybe 40, 50 hours a month that I now have that I can be actually in our centers and talking to our support staff and our frontline medical teams. What do they need to give that quality of healthcare, which is literally my title. And so that has given me back so much time. And our providers, Steve, you mentioned it. Providers want to see patients. They don't want to do paperwork. And so they're not having to, sit for hours and take an admin day to work on peer reviews. They can actually see their patients and follow up with their patients on those referrals and different things that they want to get accomplished. Taking care of not just the physical needs of the patient, because you guys know right now we're looking at the SDOH, those social determinants of health. So we can't just say, oh, he's got high blood pressure, and then, write him a prescription. Can he pay for the prescription? Is he getting healthy food? Does he have food insecurities or financial insecurities? All of those things have to be addressed at our level as FQHC. So being able to give the providers extra clinic time has been, there's no dollar amount. So just, if you need it and you want it, you find a way to pay for it.
So as a longtime CFO, unfortunately for me, this didn't exist back when I was doing this. So we actually hired another health center, and
Wow.
basically each of us peer reviewed the other one's
Mhm,
charts,
mhm,
which was better than what we did before, but it
mhm.
still wasn't ideal because it still cost us provider time. And
Exactly.
I want the providers seeing patients operating at the top of their license, us billing out for their work and everything else, because that's where the rubber meets the road. We can do all this
Mhm.
work, and if they don't generate any billable visits, we don't have any money.
That's exactly it.
Absolutely. And I know for me, my providers, every time we would ask for another admin
Mhm.
task, it was just putting hot coals. They
Mhm.
they were like, you're taking me away from what I'm supposed to be doing. I'm supposed to be
Mhm.
seeing my patients. And so provider satisfaction is hugely impacted by being able to offload this from them. And
Yeah.
I would say, in my experience, the majority of providers appreciate a truly unbiased
Mhm.
review. They
Yeah.
want to know where to improve. The ones that don't stay around long. But most of the time they want good feedback. And
They
so
do.
I think that, being able to, give them that breathing room where we're not adding one more admin task to their plate
Mhm.
is such a way to keep that longevity of your provider and your
Yeah.
organization. But one thing that sticks out for me is me and my team. At one of my health centers, I had 9 locations, over 100 providers. When we were not getting peer reviews back on time,
Mhm.
I was having staff, very well-paid staff,
Mhm.
chase them down to get the peer review. Hey, you got to turn your peer
Mhm.
review in. And so all that time and all that money of their salary,
Yes.
trying to get our internal peer reviews back on time was a
Mhm.
nightmare. I mean, it was
Mhm.
such a headache, and also then made the clinical operational staff
Right.
frustrated and dissatisfied. So
Yeah.
the cost to keep doing a process that's not working well internally is so much more than
Yeah.
deciding to
Not
say,
to
hey,
mention that
we're going to offload this.
the quality of the peer review that you get from your internal
Right.
staff is so uneven because
Mhm.
we had forms, and some of them were very thoughtful in the way they did it, but other ones were just check, check, check. It's okay, it's
Mhm.
okay, it's okay. So
Mhm.
you begin to wonder. Said, so you've never found anything wrong in any of the peer reviews you did? That's unlikely.
Mhm.
Right,
Yeah.
right.
Yeah.
Yes,
Exactly. Yeah.
very
Yeah.
much. Well, there's our truth. I didn't go. You kind of went along with them as you shared. So
Good deal.
we did want to share with you all, and I think we will be able to get this out to you as well. But we do have a peer review cost calculator that we'd like to share, and maybe that will help you as you're considering what's best for your organization. Look to see really what are we spending, to have our reviews done internally.
Yeah, and actually, I just tried it. If I point my cell phone at the screen, the QR code works very nicely.
Leave it up for a few seconds here. If anybody wants to try out their QR code here. So now surveyors, I think that is it's a really important piece of peer review because we all have to do the peer review because of surveyors, our favorite people, right? So when surveyors are coming into your organizations, they're always looking for consistent documentation. And as mentioned earlier, what's really important to these surveyors is what has my organization said as our policy and procedure? And are we following that?
Mhm.
And they will fine tooth comb everything you're doing to make sure you're aligned with that policy or procedure. I know that we've had some feedback from clients recently that they're noticing if reviews are quality. Are they truly unbiased? Was there action taken from reviews that were showing concern if that were the case? And so the reviewers, especially FTCA, I've noticed is definitely paying a lot more attention to, we say we're doing this. Are we really doing this when it comes to peer review?
So we do preparatory like mock reviews for both kinds of site visits. And I can tell you, based on, I use clinical reviewers that are the same ones that work for HRSA. And when they see someone has put a lot of effort into their peer review program, right away, you're like miles ahead because they're like, okay, these people take it seriously. They actually went out and hired a company that does this versus like, yeah, it needs to be done. So look, we did all the peer reviews 3 days before we got there.
Mhm.
Mm-hmm. Well, and
And
the proactiveness, right? It's really important, especially for FTCA, to see that you're being proactive, that you're reducing your risks. And that stands out. That leaves a very good taste in their mouth if you can show them that
And
you
you
are
talk
doing it.
about it, we all have to talk about it in our credentialing and privileging section of the FTCA redeeming application. So if you are saying that you have this policy and that's what you're doing, and then you present a quality peer review with it, you're pretty much right there. And if you can even take that peer review and turn it into a PDSA or a SMART goal and make that part of your annual risk plan that you can show progress from, then it literally becomes something else. And FTCA definitely loves to see when paper becomes action. So taking that peer review and putting it in a PDSA, SMART goals, any kind of risk analysis, and seeing, this is what we did about this finding on a peer review, that would make FTCA and a surveyor very happy.
Absolutely. Well, we want to do another poll with you all. We'd like to know what your thoughts about whenever surveyors do decide to walk on in. How confident would you be in your peer review documentation?
we also have a question that popped up, which I think is a good question. Are these external reviews only for medical, or are they also for dental and behavioral health?
For all service lines.
We use them
Yeah.
for just about everything.
Steve, this is Jared. Can you hear me?
Yeah.
For those of you who don't know who I am, I'm the CEO and founder of MedPlace. There's actually another QR code in this deck, and I think we'll make these slides available later. You'll see it again at the end. But we hear a lot working with FQs that a lot of them, it seems almost universal, aren't happy with the forms that they're using. Sometimes they don't have specialty specific forms. Sometimes they want a form that will like automatically score, so you can kind of see like at a glance how did we do on this particular one. We made a tool. It's a free tool. You can go in, just follow that QR code or go to that URL, and you can it generates forms for you. So it'll you put in like on the right like what specialty you're trying to do, or if you want it to be general, and then it'll end up creating a PDF for you that automatically scores itself. So hopefully that's helpful to somebody. But we thought it would be, just because we hear it all the time, we thought you guys would appreciate it.
Well, it definitely is because the way most health centers get these forms, because I usually ask them, so where'd you get the form from? And usually it's another organization gave it to them. And in some cases, I looked at it and said, this doesn't look like an FQHC. Did you get this from a hospital? Oh, yeah, my cousin works at a hospital. I said, well,
Yeah.
this just, that's like not exactly what we need here. You need one that's tailored to what you do in your kind of organization.
Yeah,
Yes.
and we use this as kind of best practice, but you've got your 5 charts, you've got the table of questions, and you've got your comment sections at the end. And anyway, it's nice and it's pretty customizable. So if you have any problems, there's a little support email that you can ask for help. But we hope that you guys enjoy it.
Jared, that was one of the deciding factors for Franklin to go with MedPlace was the fact that we sent them every version and we had every version of a peer review form, one for providers, one for dental, one for behavioral health, one for optometry. We sent all those to you guys, and you asked us then also, what did we want to accomplish with our peer reviews, and came back with that wonderful template that we still use. And even 2 weeks ago, Misty, we made some changes to it when we
Yes.
realized there was some redundancy. So, like I said, it becomes a part of your team. It's not just a document anymore. This
Yeah.
becomes something that you can rely on as a team member to give you great information and feedback. So that was one of the things that really attracted Franklin to MedPlace was the fact that the templates that were customizable to the services that we provided, to the strategic plans that we had, and to the quality and CQM goals that we had set.
It's great.
No, that makes
Well,
sense.
and I think it's also important to call out, which Sheree, I know, is very excited about this. We've been able to optimize our forms, and with our new e-forms, we will be able to do some very robust reporting, trending,
Yeah.
where you can actually be even more proactive with seeing, oh, Dr. Shell did this 3 quarters ago and has improved, or Dr. Shell's worsening all the time. So what do we need to do? So, I think that being able to have that support to then ask for what you need. We need more training. We need to put a quality initiative in place. We need corrective action. And it really the form is a very big part of that, right?
Yeah.
Because it guides the topics that the organizations are really looking at and trying to hold themselves to standard too.
So I'm going to end the poll. We have 145 people have responded. And it looks like 33 are very confident, which is great. I'm glad you are. It seems like the majority, 82, are somewhat confident, but we have 30 people who are not very confident at all.
Yeah, I definitely was in that not very confident group before we did the transition to MedPlace. And it just because it was inconsistent. It was just inconsistent. The data just could not be validated. You couldn't trend anything. I just didn't have anything to support these pieces of paper that we were collecting, every quarter or so often when we could get them back. It just was too inconsistent. And one thing about survey and accreditation is consistency. And so it just was something that I didn't want to trust to, spreadsheet that we had floating around since 2018. Yeah, it just wasn't enough. We needed it a little bit better. Not that it wasn't working, it just wasn't the best we could do.
So I noticed I have a comment here about the form generation link not working, and I clicked it myself, and it looks like it's going to a sign-in page that needs an account.
All you do is you just need to sign up. There's a little link says don't have an account, sign up.
Oh, there you
what
go.
click
Okay,
on
there's
from
your
there.
answer. Don't have an account, sign up. So I didn't see that either. So I have a few questions that came up. First one, what would be a good consistent interval for peer reviews? Monthly, bi-monthly, quarterly?
Well, there's no rule. So whatever your policy says is the best thing to do. If you really want your peer reviews to be something that the organization can use to restructure processes and to grow, I personally feel that, based on the experience and different things that are happening here at Franklin, that quarterly is the best way to go. And you got 4 great reviews all year. That gives you 4 quarters to act upon those reviews, make changes, share best practices with other providers who may not be doing as well. It just gives you a whole full amount of data to be able to go and see really what's going on with your charting and your quality.
Something else to point out, we have a lot of flexibility at MedPlace. So when we're supporting organizations, we just had one recently reach out and say, hey, I have a concern about a provider. I would like to do monthly peer reviews on this provider for the next year. And so we're able to flex that and say, okay, we'll start doing monthly for that provider for you. And so it also can be a tool in the redirection of a provider when there's corrective action. Maybe that's a part of the plan of we're going to do some training with you. We're going to give you a mentor, and we're going to peer review every month for a certain amount of time. And so they're able to really have that data and that feedback that's unbiased to see, is the training sticking? is the person making the adjustments needed.
Well, and the thing that's nice about that, I mean, we also did that internally, but of course, whoever we asked to do it, it's like, okay, you can't say anything to anybody that you're looking at their stuff more. So here you have more confidence that there's not going to be a leak because basically three people can keep a secret if one of them is dead. You know, that's what they say.
That's a
And
great call out.
we always had a problem with that. A couple more
Yeah.
questions. How many charts do you suggest are reviewed each quarter?
Again, it goes back to your policy. There's no golden rule on how many. You know, we could go more now that it's done through MedPlace and it's a lot easier to do them that way. But back when we were still doing them manually, we did 5 per provider per quarter. And something we haven't touched on, Misty, and I think is such a huge piece of this, and I can't believe we haven't brought it up. MedPlace can get integration into your EHR. And that was another huge piece for Franklin because we use Ocean Epic. So when we knew that Ocean Epic was letting MedPlace in, that kind of said, okay, they must be pretty good at what they do. Because if you have Ocean, you know, Epic, they don't let any vendor in. They are very select in who they let access their charts. So we gave MedPlace how we wanted them to choose the charts. We chose, I think it's 3 annual wellness, a new patient, and a hospital follow-up. So those are the kind of visits or encounters that we ask MedPlace to find those within our system every quarter, 5 of them on each provider, and then they gave us that feedback, and it's been just game changing. I just can't say enough of how much it's made my life so much easier as director of healthcare quality.
So that answers the question someone had about interface
Yes.
compatibility. You know, the other thing I guess I would want to ask is, so let's suppose you do X number of charts. Let's say you do 5 charts per provider. Is it possible to set it up where if you find certain deficiencies in one provider's chart, you automatically do more charts to see if it's just a statistical anomaly or, you know what I'm saying? So you maybe dig a little bit deeper?
I always say anything's possible. So we're very flexible. So if we had an organization approach us and say, you know, hey, our providers that scored this amount, we would like then to do another type of review, have another expert take that review and maybe do 2 reviews, or sometimes they will ask for a standard peer review. So they'll say, we only want to focus on this provider. We want to send a bunch of documents over a longer period of time and have a very deep dive on what this provider is doing. So sometimes it does transition that way. So we have a lot of different ways we can meet that need and whatever makes the most sense for the organization.
It's great to have that flexibility. So what we were talking about, the last question is, so that's 5 charts a quarter you were talking about, not a month. You're only doing quarterly, so that would be 5
quarterly. Yes. 5 per provider per quarter.
Per quarter.
Okay. And most of our clients do 5 to 6 charts per provider.
Now, somebody wants to know where the reporting results and forms are housed.
Yeah, so that's in our MedPlace platform. So when you sign up to partner with us, you would be given a login, you and anyone else that you would like on your team to have access to the reviews. And the review reports are housed in the platform. Our reporting also will be, as it's developed, housed in the platform as well. We are able to, just as part of the operational workflow for you all, like Cherie said, we go in and we pull the charts out of Epic for her. We're able to do that. We upload those into the platform. We also have clients that prefer to do that on their own. And they go in, they upload the charts per provider that they want reviewed. From there, it gets matched to an expert. And then once the expert completes the review, we have a team of nurses that do a clinical quality check just to make sure everything looks correct. We also are very nice and we like to check our spelling for our medical experts. We know everyone's busy. And then once we gold stamp that, it gets published back out to our client.
So which systems besides Epic are you guys able to get into?
Oh goodness, Cerner. We are on eClinicalWorks, NextGen, Athena. And we've been able to access Ocean and Epic and are in the process of accessing Epic directly with a client.
Okay, so someone had asked about Athena 1, so that would be affirmative on that one.
Now, I will say, while we don't currently have a direct interface for that chart pool, we do have it on our radar. We do have to be given a login. So a lot of places treat us like a quality vendor, and then they will get us a certain number of logins where we can go in and access the
No, that makes good sense. Now I have a very specific question here. It says all providers in our group get a computer-generated report on our cancer screenings, diabetic patients under control, hypertensive patients controlled, depression screenings. Isn't this peer review?
No.
No.
That's usually care gap closure.
Yeah, exactly. That sounds like care gap closure. And it almost just sounds like, just looking at those CMS quality measures, that's something that we use as Zara and we send out their report card to them. A peer review is actually going into the chart of a encounter that provider had and someone looking objectively to see, did they meet the standard of medical care defined by what your company or your organization says the medical care should be? So, if there was, were the referrals, correct and just with the diagnosis? Do the diagnosis and the care plans match the patient? So it's a lot more than just, did he select the correct box for cancer screening or was the A1C normal? Or it's a lot more than that. It also, some of the feedback that I'm getting from my providers is that they've even learned how to chart better and even think more about what they're ordering. One of our providers just, she likes to order labs, and after a couple of peer reviews, the reviewer just said, are these necessary? Can you just do those at an annual wellness? And so that cuts down costs to the patient, or if that patient wasn't able to pay, that's a self-pay that, the organization doesn't have to absorb those lab costs. So again, it's a lot more than just, are they doing their job? This is a glance into how they do their job and can they do their job better. And I think that's what's most important for another provider to say to another provider. They don't want to hear it from Misty and myself. We're nurses. We are good at what we do, but I can't tell an MD or a DO or NP how to do their job better. So hearing it from someone with the same credentials or higher credentials than them, because some of the reviewers are extremely impressive. And that's another thing, as a client, you get to see the CV of the reviewers before you select them to review your charts, which I really like because I have specialties. I don't want family medicine looking at OB because OB is going to say, well, he doesn't know what I do. So for that reason, I pick an OB provider for an OB peer review. So, it just allows you to just learn and get some really great objective and subjective feedback on how you work.
Well, which is also a problem if you're doing it yourself and you only have one of a specialty, so you don't have anyone to review them. And only in my wildest dreams did one of my providers ever do a utilization review on something like labs and because literally they knew that if they started criticizing the labs you were ordering, you were going to start criticizing the labs they were ordering. I had some providers that never met a lab they didn't want to get. So another question is, can the peer review be used to meet the FTCA required quarterly risk assessment?
Oh, that would be a stretch. That would be a really great FTCA question when they start their after hours. I don't know if I would personally do that without
but when
it
you
being
say
somewhere.
When you say meet the required quarterly risk assessment, I think it could be a very valuable component of the
100%. I use
quarterly assessment, but I don't think you can just do. I don't think you can just do a peer review and ignore everything else. But I think that if you're doing a very professional job with peer review, it's going to go a long way to meeting the requirement.
Yeah, 100%.
Next one, I think I know the answer to this. Can you request specific charts to be reviewed if there's a specific concern, like for cause reviews?
Yes. So not only do we offer what we call our quality cadenced peer review, we also give the ability to our clients to request one-off reviews. So if you have a provider that you're concerned about, we can do a standard full review, or we can even do a small limited review where it's just 5 to 6 charts. We see that a lot with clients who have a newer provider. They may, after they've been there a few months, say, hey, we'd like to do maybe just a one-off review on this provider, just to see how they're doing, so that we know if there's any training opportunities for them.
Yeah. So, Misty, that's true because we do like 30, 60, 90. The first two are done in-house, the 30 and the 60, but the 90-day, we reach out to you guys and we'll say, can we get a spot review on this provider? And we use it as their 90-day evaluation.
I've got a whole lot more questions. We're gonna be a little busy. Can you delve a little bit more into the scoring rubric?
Yeah, so we work with our clients. Some of them have their own scoring parameters. We also are willing to help you decide what that should be. We know a lot of our centers use the stoplight, the coloring for when something is passing, maybe needs attention or failing. So we do the red light, green light, yellow light a lot. And we really work with you to decide. You might say anything above an 85 is a green. Anything that is a 75 to 85 is yellow. And if I want 75 or lower to be a red. And so whenever we're sending those reports back, you have a quick glance at your scoring tool to see, what's happening there. Let me see if I have.
Misty, while you pull that up, I just saw a question that was such a great question. Tina was asking, and this is something that when we started I asked the exact same question, Tina, is do you have to wait to the end of the quarter to pull the charts? Or can you go ahead and like pull quarter four? And that's one of the things that we did, Tina, if because there was enough visits by like halfway through the quarter that our very first one, we did not wait till the end of the quarter. We did start before the quarter ended. We just used the first 2 months of the quarter so we can get them back. But now we just wait till the end of the quarter because I think we get them back within like the first 2 weeks. I've been able to get my reports back from Medplace, have that data ready for my CMO. Usually when I send in my monthly report to him of, the productivity from the previous month or quarter, it's usually within the first 2 weeks of the month. So it's not a slow process that you will get your reviews back in time for any kind of quarterly meetings you may have, but you can pull those before the end of the quarter. You can do them like with the first 2 months of the quarter.
And back to that flexibility, we just recently had a client who had a really important meeting coming up, and there was about 6 or 7 providers that she really wanted to have that review information for them a little early. And so she reached out and she said, can you get this to me by the 7th of November? And we're like on it. So I'm able to pull those charts, get it over to our medical expert, and she was able to take that data in with her to that meeting. So we're willing and able to do that as well. I wanted to just show you this. So here's an example of one of the peer review reports. The scoring up here, all of this coloring is customizable. So if you decided you wanted to do a red light, green light, yellow light color cadence with scoring, we could do that here. So when you get that report back, your eye is immediately drawn to, do I need to pay attention to what's happening with this provider? Our reporting that is being optimized will be coming out this next year. You can see some of that here, showing question level compliance for your providers. You can do a comparison to see how it has changed since the last review. And then you can also trend out your providers compared to other providers or compared to their department, which is really just a huge benefit because I know many of you are going to those meetings on sometimes a monthly basis and being able to have nice, clean data that shows, hey, we did this training with our providers. We did a quality initiative. We're able to show you that had a positive impact. Or, hey, we're seeing a decrease in performance around something. We need to vote to do a new quality initiative. So it's a powerful decision tool for clinics.
So I had somebody asking about the specialties. You've already said you do dental, medical, behavioral health. Do you do things like chiropractic and acupuncture as well?
We do. Yeah. We all endocrinology. We have some cardiology. So some of our
pediatric dentistry. Maybe I had another question about pediatric dentistry.
Yes, we do have some pediatric dentists. We have currently 3 pediatric dentists who work with us as experts who have amazing backgrounds and FQHC experience as well.
That's outstanding because we could never find people to do that.
Yes. They are a diamond in a rough. They are.
So when audited by HRSA or FTCA, do they often asked to see specific results from the provider peer reviews.
Mhm. Yep, when they do look at your credentialing and privileging, they will ask to see the peer review, clinical competencies, their continuing education, all of that is asked for when they're looking at a credentialing file.
Well, that's really valuable to have this done in the way that you're talking. So let's see. I mean, I actually have more questions than we're going to be able to probably handle. Optometry, podiatry.
Mhm.
Yes.
So someone said, this is interesting. I'm being told that we're not in compliance with FTCA if we wait until after the quarter.
Yeah. Yeah, I messaged Tina. I think Tina, the best thing to do is reach out to FTCA. I've never heard that. And when they have those off after hours where you can just message them questions, whatever, they literally will answer your questions. They are not going to there's no dumb question. I've asked them some things I'm thinking, now that they're gonna, really look at my file when I submit. But yeah, it's okay to ask those types of questions. But for me, the best thing to always do is to go to the source. There's a lot of hearsay out there about what they're looking for. Joint Commission, every survey, someone comes out, oh, well, they, surveyed us on this, and NCQA now wants this. Go to the source, or if you're really concerned, someone like Steve, who's a consultant, if your organization will let a consultant come in and look at it prior to your submission, that's always great as well. And mock, anything that you can do to get just an extra eye on it outside of that. But
So,
just it's best to go
so
to the
yeah,
source.
so we have experts on FTCA and quality assurance that do it. Obviously, I don't do it because it's not my area of expertise. So ask me anything you want about the UDS. Not today, another time. That's something I do, or grant application, but the clinical care is totally
Yeah.
out of my bailiwick. But if you reach out, we can absolutely help with that. Um, I know you guys, we are running short on time and we still have questions. And I think, as far as I'm concerned, I'm willing to go a little long if you all are willing to stay
Yeah,
on for a few
absolutely.
extra minutes.
Yeah.
So if you folks have
I'm
a
going
little
to go
extra time.
ahead, Steve, if it's okay, I'm going to go ahead and share the slide. If anyone's interested in meeting with us here at MedPlace, we would love to meet with you, hear about what your pain points are, how we could be of service to you. So definitely reach out and schedule that time with our team. But I know some people might have to drop, so I wanted to get that up for everyone.
Yeah, and while we're on the subject, since we have so many questions and we're running long, I am going to drop another poll, and let me find the poll thing here. And this poll is going to be our one that we always do on the contact poll to see if it's okay for these guys to reach out to you or put you on their mailing list. And just so you know, nobody's going to hard sell you or anything, but these guys are really generous with their time and their experience. So I would absolutely um, recommend letting them talk to you, because I've learned so much about peer review that I had not picked up in 42 years of doing this. So just a hugely valuable resource. So do you have some other slides that you need to show, or do you want me to just continue answering questions or having you answer questions?
Yeah, I think answering as many questions as we have
Okay, then
is,
I will do that.
yes.
Um, I have a question about, I knew somebody was going to ask this, cost of peer review per provider when done. Now, I'm sure that's always complicated, but can you give somebody any idea of the ballpark that we're playing in?
I'm going to punt that to Jared.
Yeah, it depends a lot on how many providers you've got, term, things like that. But it's generally, if you're comparing it to like time for your experts to be, and it also, by the way, depends on who you have reviewing
Mhm.
your provider. You can have mid-levels and others review providers. Those are options. So it depends on a lot of things. So it's hard to give a price. But if you ever want to get pricing, you can reach out and book a demo, and you will get pricing after that based on exactly your environment and what you're trying to do: quarterly, annual, semi-annual, that sort of thing.
Okay, well that's what I would expect from a complicated thing, especially some of these are some subspecialties, which I imagine are
Mm.
hard to get reviewers for. So I would definitely, I'm guessing that the pricing would be based on the type of clinician or provider that, but I mean, again, I can tell you based on analyzing the cost of peer review that we did, taking my providers out of their environment of seeing patients, literally the losses of productivity and revenue, considering the percentage we had on Medicaid and our PPS rate and 340B prescriptions that didn't get written and everything else, it was a breathtakingly awful number to have them doing it. And I can't imagine
Absolutely.
that the cost of having it done by a competent organization like this would even come anywhere close to what it was costing you to have your staff doing it. And that doesn't even address the difference in quality of what you're getting. Because
I was
Right.
going to say that too. Yeah, I don't, of course, everything costs and there's a dollar amount to everything. But again, I think I said this before, giving myself back 40 to 50 hours a month was priceless to me because now I'm actually out of my office and the support staff and the operational staff, they can see me and they can ask me questions and we can talk and we don't have to get ready for Joint Commission. We stay ready for Joint Commission and because I'm out and about now. And my CMO, he still has a full patient load. He has 2 admin days, but he still sees patients. And so for him to have to wait on me to gather all this information, get it to him, for him to look at it, where now I can present him one page on an email. This is what they scored. These are the scores that we may need to look deeper into. Internally, would you like me to set up a meeting with you and that provider? However he wants to proceed, it's now a conversation instead of back and forth emails throughout the entire year, trying to just keep up with the process. So it is, yeah, I know it costs, and that's the thing. I'm in Mobile, Alabama. We're down here in in a very, very, very poor area of the country, but it's something that, myself and my deputy, we did the research. We found the best option, which was Medplace. We wrote the proposal, and we just, had to wait for the amazing answer. And when it came, we were extremely happy. Your organization, if they have a strategic plan that's set from your board, or they want these types of accreditations and these type of redeeming applications, they will invest the money. You just have to make sure you get the right information to them and present it in such a way, and MedPlace will help you with that. They'll be right there with you, answering the questions from your CFO, who's going to ask a different question than a clinical person would ask. So, all of that, just start the conversation within your organization, and you'd be surprised the responses you get from the C-suite and your board of directors.
Yeah, I think
And
Well,
none of
Sri, I
the,
don't know if you
well,
had the same experience as me, but one of our initiatives was provider satisfaction.
Yes.
And the way we started doing that was if we had to have them do admin tasks, that means we try to do it within their normal workday.
Hours.
And that when we were doing our peer reviews, I was losing 3 to 4 patients during that hour. If it only took them an hour. Some of them, it could have taken them 2 hours, and I'm losing 6 to 8 patients that we could be seeing. And that's tremendous when you look at even that cost. Not only am I paying the provider for that time, but I'm not getting any sort of revenues from the patient visits for
Right.
that
like I
one.
said,
Yeah, when you
as a
compare,
CFO, no brainer.
yeah, when you compare along that of like reimbursement rates and missed opportunities, it's far less. The cost is far less than than that.
I agree. I agree.
Our FQHC reviews quality metrics, patient satisfaction, and other metrics each quarter for our 250 providers and is presented to our peer review committee, who makes recommendations for low-performing providers. Our chart reviews are at the time of RE, C, and P. We have also had our OSV and ended up being compliant in this area. Well, I have to give you my congratulations for 250 providers. But again, even if you're compliant with your OSV, which we were too, but the thing that I couldn't get past was the opportunity cost that this was costing me. Because if you have 250 providers that you're doing peer review for, you're essentially over the course of the year devoting 1 or 2 FTEs. I mean, they're not all one person, they're little pieces of person, but imagine how many visits you could generate. And if you look at what a provider generates, and again, they might have passed OSVs, but as someone who prepares people for OSVs, I can tell you that I've had lots of clients where we're very picky. So we come in and we find all kinds of stuff wrong, and they say, well, we had our real OSV and they didn't find any of that stuff. And I said, well, that's because we're trying to be the worst case scenario of what they're going to find. There's a lot of reviewers that, as long as you're doing peer review, they say, yep, you're doing peer review, check,
Yep.
you pass. So I don't know that
Yeah.
the OSV, I would set a lot more store on the FTCA reviews that are just starting to happen, because these people are uber picky about everything. And as we've seen from the question on this call, I think they're even more picky than they're allowed to be. So congratulations for doing that, but still, I think that it's a huge strain on every organization to do this.
We were never cited on OSV for the processes that we had prior to Medplace. I mean, like I said, we've had these accreditations for years. We've been in business for 50 years. It wasn't that. It was that, could we be doing it better? Basic was not acceptable. We're Franklin Primary. We didn't want to be basic. We wanted to do everything that we can at the best of our ability. And also, that peer review has now changed policy. It has changed education, onboarding, and retaining of our providers. It has changed the workflow of our EHR and how that looks, our work queues. It's changed a lot of things. It has become a member of the quality team. It's not just something we did for accreditation. It's something that we do every day, refer to often throughout the quarter, because we can use that for PDSAs, for those risk analysis and different things that help us grow as an organization and provide better care. Our CQM quality measures on certain things like A1C and controlling hypertension and cancer screening have increased because the providers who were not clicking or scheduling those got it back on their peer review, and so they started doing it. So it's had a huge effect on the outcome of this year's reporting that we're going to have to do. So for that reason, great. It's great that it passed OSV, and let's hope that every surveyor agrees with that surveyor. But it's more than just accreditation. It's about the quality of work that you do. And when you have things like NCQA and Joint Commission, and you call yourself a patient-centered medical home, you got to do a little bit more and grow every time. Have the opportunity to grow and improve.
And I was going to say, Sheree, the most recent health center that I was in operations leadership at, we were really shifting our strategy to focus on payer incentives and PCHH, patient-centered health home. And this peer review process, the impact of being able to really capture and be proactive, was that second blood pressure taken?
Yes.
If they were elevated, being able to have those kind of questions on a peer review, even though you can pull a lot of reporting, being able to understand the consistency of, is this provider doing what they're supposed to provide that care? Because we all know that payers are going towards quality. They're going towards optimized care. And staying ahead of what the providers are doing and the decisions they're making is more impactful than it's ever been.
Yeah.
So you bring up a really important point, because I have a client that basically asked me to help them with some of this payer stuff, quality stuff. And I had to go and be on all the calls. And one of the things that was expected of the staff was more of this going into charts and pulling stuff in order to monitor how you were doing on the quality awards. And I have to say that this particular client was not coming anywhere close to the amount of quality award that they could have gotten. So number one, it was a huge drain on the staff, and they literally just didn't have time to do it. So it just wasn't getting done. So having you being able to do this for them, I'm not even convinced that you couldn't pay for a large chunk of this just with the extra quality incentives that you're going to get from the third-party payers, and not even have to dip into the saved opportunity cost from the provider, which I hadn't really considered before.
Sheree, I don't know if it was your form that we just changed to add, was medications mark reviewed?
Yes.
Because that was huge for me in PCHH.
Yep.
I had to make sure that was happening as a part of my PCHH, stamp of approval. But also payers are wanting to know, are your patient's medication lists being reviewed consistently? And so whenever you can have these reviews pulling out, Dr. Shell is not doing a good job about making sure that medications are reviewed. It lets you very quickly go, okay, we need to do a training with Dr. Shell because it doesn't look like anyone else is having that problem. And so I think it just gives that extra kind of cherry on top of we're able to really keep our eye out for opportunity. And payer incentives are not going away.
No.
I think they're just going to get worse. And so, I think the more that you can do to stay proactive and to really be the ones that decide which way your ship shifts and goes, is what's going to have to happen. Because if you're constantly being reactive, you're never going to meet the measures to get those incentives, even grants.
So
yes, perfect. Yep, perfect.
An outstanding peer review program can help you with grants.
So I did have one other thing to address. So somebody had mentioned that they were having some issue with the with what you allowed them to download. So what I would say is anyone who, if you're trying to download something and you're having any issue or you have any questions, who should they contact at your organization to help them out?
They can email support@medplace.com. It's an easy place to ask a quick question. So that's support@medplace.com. You can see Misty's email there. Don't use hers, but it's the same extension.
Thank you. I appreciate that. I just put that email in the chat as well.
Oh, so you're not going to put your home phone number on there? No, okay. So I have looked at these materials and they seem to work fine for me. So I'm sure this is something that we in IT face all the time, that you have a lot of people on a lot of different systems and having a lot of different issues. But this is some pretty good stuff. So does anybody have any more questions? If not, I'm going to let these folks go. And I would just want to thank you all. Misty, Cherie, and Jared, I didn't get to introduce you at the beginning, but you all have done a great job of explaining this. I know I've learned a lot today. And now I'm going to go into my garage and try to build a DeLorean so we can go back in time and you can be at my health center 15 years ago to help me with this stuff.
Awesome.
So thank you, everybody. As we said earlier, this is going to be recorded. It's going to be available in the community, fqhcconnect.com, if you're not a member. And we will also be providing the slides. So thank you, and everyone have a wonderful rest of your week, and hope we see you in another webinar real soon.